Hi, I'd like to introduce you to a seminar called Living with Hypopara Sometimes is a Side Effect of Thyroid Cancer Treatment. Dr. Levine, who has worked with the Division of Endocrine and Diabetes and is the director for the Center of Bone Health at Children's Hospital of Philadelphia, is going to be speaking today. He is one of our most valued and trusted resources at the HypoPARAthyroidism Association, and he's also a medical advisor. Oh, I forgot to announce myself. I'm Deb Murphy. I'm also on the board of directors for HypoPARA. And without further ado, I'd like to turn it over to Dr. Levine.
Well, thank you, Deb, for that introduction, and welcome to everyone attending this session. As Deb has mentioned, I'm an endocrinologist in the Division of Endocrinology and Diabetes. I'm trained in both adult and pediatric endocrinology, and over a career spanning, let's just say 40 years or so, I've had the opportunity to meet patients of all ages who are dealing with the challenges of living with hypoparathyroidism. And this afternoon, I'll give you a little bit of insight into some of the challenges that you share with your physicians, because management of hypoparathyroidism requires a partnership between the patient and the physician. And I like to think of this as a marathon and not a sprint. This is a chronic condition. We're hopeful that in the coming years, we'll have new advances such as stem cell technology to replace missing parathyroid tissue. But in the near term, we'll still be dealing with conventional therapy and soon the availability of new forms of parathyroid hormone. But by and large, this is a chronic condition, and we don't see a cure for this in the near term. By way of disclosures, I would tell you that I received grant support for clinical studies of NatPara, PTH1 to 84, from ThyCa Shire. And I'm a member of a scientific advisory board for ThyCa Shire as well. So let's jump right into this. I'll give you my definition of hypoparathyroidism, which is one that has emerged from several recent workshops. This is a clinical disorder characterized by hypocalcemia, hyperphosphatemia, and I'll keep coming back to that because this is so important that you recognize that hypoparathyroidism is more than a low serum calcium level. It's also an abnormally elevated serum phosphate level. And of course, insufficient PTH. And by that, I mean a PTH level that is too low to support normal levels of calcium and phosphorus. Some patients will have measurable levels of PTH when they get a blood test, but even a PTH in the normal range, in the presence of a low calcium and an elevated serum phosphate level, is in fact consistent with hypoparathyroidism. Now, let's spend a little bit of time talking about parathyroid gland history. And you should know that the 4 parathyroid glands were the last endocrine organs to be discovered. And they were discovered in 1849 by Sir Richard Owen, who was working at the London Zoo at the time. And during a necropsy, so an autopsy of an animal, in this case, an Indian rhinoceros, he discovered 4 glands in the neck that no one had ever identified before. And because they were near the thyroid, he named them the parathyroids. And those of you who have surgical hypoparathyroidism as a result of a thyroid cancer operation, and I'm sure that's nearly everyone in today's audience, will no doubt find it a little bit ironic that this picture, in homage to the rhinoceros, hangs in the Hunterian Museum, which is part of the Royal College of Surgeons in London. Now, in terms of understanding the parathyroid as a gland in humans, well, it took a number of years after Sir Owen's discovery in the rhinoceros for Swedish medical student Ivar Sandström to identify human parathyroid glands during a medical school project that he was involved in. And he very proudly presented his results at a meeting of the Swedish Academy of Medicine. And because in 1880, neither he or anyone else had discovered what the parathyroid glands actually did, his discovery really made no impact in the room at all. In fact, the only person to compliment him on his discovery was a German professor who had not even listened to his presentation, but felt compelled to encourage a medical student. It wasn't until 1906 when Austrian pathologist Jacob Erdheim discovered a purpose, a role for the parathyroid glands. And he was doing autopsies on a series of patients who had severe bone disease, something we call osteomalacia, which is similar to rickets in children. And he discovered that all of these patients had grossly enlarged parathyroid glands. And so he concluded that the parathyroid gland and the secretions that they emitted, parathyroid hormone, were somehow related to calcium metabolism and bone diseases. So that brings us today. We know, pardon me, that there are 4 parathyroid glands. They lie nestled in the wings of the thyroid gland. And for most patients in the world, hypoparathyroidism is a surgical disorder. So I like to think of it as the result of surgical misadventure. And nearly 8% of neck surgeries are associated with some damage or removal of parathyroid glands. Occasionally, a parathyroid gland will be removed knowingly because it can't be saved, it can't be pushed aside during thyroid surgery. Sometimes they're not noticed, and only in the pathology lab, when the pathologist is sectioning through the thyroid, do they discover a parathyroid gland. And more often than not, the parathyroid gland is damaged during surgery. Sometimes when a surgeon knows they damaged a parathyroid gland, they will try to remove it and reimplant it. And that's only successful about 50% of the time. So in about 75% of patients who have some parathyroid damage, there'll be transient hypoparathyroidism. And that means that within 6 months, parathyroid function will be restored. But in 25% of patients, this will be permanent hypopara. That means 6 months after the surgery, there's still hypocalcemia, there's still elevated phosphate levels, and PTH levels are either absent, low, or in the normal range, but not high enough to control the calcium level. And overall, about 0.5 to 2% of all neck surgeries will result in permanent hypoparathyroidism. And we know from studies done by the American College of Endocrine Surgeons that the more thyroid surgery a surgeon does each year, the less likely they are to cause surgical hypoparathyroidism. So this really is a function of experience and expertise. So this afternoon, we're going to address 4 questions, perhaps not as momentous as the 4 other questions that I often am called upon to answer each spring by my family at our Passover Seder. But today we're going to talk about 4 questions that I know are at the top of your mind. The first is why calcium is low and phosphorus is high in hypoparathyroidism. The next will be the signs and symptoms. Thirdly, we'll talk about your treatment options. And last, we'll talk about complications and monitoring. So why does the serum calcium level go down and the serum phosphorus level go up in a patient who has hypoparathyroidism? So we have to look at all the components of mineral metabolism to understand this. So here we have the thyroid gland, which is a bystander for the most part in this discussion. But these four little yellow features are the parathyroids. We have bone, we have the kidney, and we have the intestine. So all four components have to work in an interrelated way with parathyroid hormone and vitamin D in order to maintain normal serum levels of calcium and phosphorus. So what happens when the serum calcium level goes down? Well, normally, this reduction in serum calcium will be detected by the parathyroid glands, and very quickly they will increase secretion of PTH. And the most immediate effect of PTH will be to increase the removal of calcium from storage areas of the bone. So this occurs almost instantly. Calcium goes down in the blood, PTH is released, and it acts on the bone in order to restore the calcium to normal. The second thing that will happen when PTH increases is that there'll be renal effects. And in the kidney, there'll be an attempt to prevent calcium from being lost through the kidney into the urine. And there'll also be an attempt to suppress phosphate levels by pushing phosphate out through the kidney. Why? When PTH acts on the bone to release calcium from storage pools in the bone, it's also releasing phosphate from the bone because the mineral in bone is composed of calcium and phosphate, something called hydroxyapatite. So when you break down bone, you release calcium and phosphate, and you only want the calcium. So in the kidney, PTH will try to reclaim the calcium from the urine and push out the phosphorus into the urine. So the two important things that PTH is doing in the kidney in order to maintain the calcium elevation that's occurred because of release of calcium from the bone. But there's more. In addition to the effects of PTH on calcium and phosphate reabsorption, PTH will also increase the conversion of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D. And that form of vitamin D is also called calcitriol. So this is the active hormonal form of vitamin D. And it's only made in the body in response to PTH. So if you don't have PTH because of hypoparathyroidism, you cannot make calcitriol in your own body. And because you can't make calcitriol in your body, you're not able to absorb calcium in your diet or from supplements that you take. So that's a very important role for calcitriol. And if you can't make it yourself, you have to ingest calcitriol as a drug. And calcitriol will also increase calcium from storage pools in the bone, because we know that between meals, patients with hypoparathyroidism who are taking calcitriol will be able to maintain a normal calcium level. And because this is between meals, that calcium is coming from the bone. And then lastly, the effects of PTH and calcitriol together will restore the blood calcium to normal and prevent an elevated phosphate level. So you need two hormones, PTH, calcitriol, and you need parathyroid glands, and you need the intestine, you need a kidney that's functioning normally, and you need a skeleton. So this is a very complex system. What are the signs and symptoms? Well, Most of you know these better than I do. This is mostly neuromuscular. You feel tingling in your hands, your feet, or around your face when your blood calcium level is too low. And let me, I think, reinforce the notion that sometimes patients can feel these symptoms even when their blood calcium level is within the normal range or within a target, because that level of calcium isn't normal for that particular patient. So in medicine, we know that everything we measure has a very large and broad reference range. And some people require calcium or thyroid hormone or whatever you want to measure to be at the upper limit of that reference range for them to feel healthy, whereas other patients will do quite well when the level is at the lower end of the reference range. So one size doesn't fit all. And if you're feeling tingling in your hands, feet, or face, and you know your calcium level is too low, and your doctor measures your calcium and says, I don't know what you're talking about, your calcium level is within the normal range, you should start a discussion about that may not be normal for me. Now, if calcium levels go down extremely low, patients can have a difficulty breathing. They can have laryngospasm or even look as if they're having an asthmatic attack. We can also see muscle spasms and cramps, particularly after exercise. And patients who have underlying seizure disorders may find they have more seizures. Now, one manifestation of tetany can be elicited by tapping on the cheek right in front of the ear. And if you see this sneering face, the upward movement of the corner of the mouth, we say that's a positive Chvostek sign. And you can do this on yourself in front of a mirror. And the lower your calcium is, the more robust the response will be. And I tell patients all the time, if you're feeling a little low, tap yourself on your cheek, look in the mirror. Are you doing this? If your whole face is twisted, your calcium level is really low. A friend can do it for you. It's not like tickling. You can't tickle yourself, but you can do this to yourself. And about 15% of folks who have normal parathyroid glands, who have normal calcium levels, can have a slightly positive Chvostek sign. But when the serum calcium level is very low, you'll see an incredible Chvostek sign, maybe almost like this, which raises the question, did Elvis Presley have hypoparathyroidism? Well, perhaps not. We'll never know. Now, another sign of a low calcium level is the Trousseau sign. So you can see it depicted in this slide, these two fingers almost looking like they're walking across the table. And some of you, I'm sure, have experienced this when a blood pressure cuff is placed on your arm in the doctor's office and they're checking your blood pressure. When the blood pressure cuff is inflated to a very high number, it pinches the nerve in your arm. And because the calcium level will set how sensitive the nerve is to any stimulation, if your calcium level is low and you pinch that nerve in your arm, it will elicit this sort of sign. And that means your calcium level is really low, and we get worried when we see this sign. What are some of the other manifestations of hypocalcemia? Some patients can have recurrent headaches due to increased pressure in their head. This occurs when the calcium is low, and sometimes when we prescribe calcitriol for the first time. Patients can get recurrent headaches, and that's because of increased pressure within the skull. If the calcium level gets very low, patients can have heart failure. And sometimes we can see some of these changes on an EKG. So when I have a patient who has a low calcium level and I'm trying to decide, should I admit them to the hospital for treatment, or can I keep them at home and give them more calcitriol and calcium, I might do an EKG. And if I see signs on the EKG, I'm really worried, and I'll admit that patient to hospital. And then With long-term and chronic hypocalcemia, patients can develop depression. We know that the quality of life is reduced, and many patients, perhaps some of you in the audience today, will have experienced something that we call brain fog. There are some other manifestations of hypoparathyroidism that people may not have told you about. With long-term hypocalcemia, with elevated phosphate levels, so low calcium, high phosphate, patients can develop cataracts. So patients with hypoparathyroidism should make sure that on an annual basis, they are evaluated by an ophthalmologist who can dilate your eye and look to see whether you are developing a cataract. This can affect vision. In addition, you can develop calcium deposits in the brain, and you can see here over time just how extensive this white material, which is a calcium deposit, has occurred in these different patients. In most cases, this doesn't cause any neurologic problems, but in some patients, this calcium in the brain can cause movement disorders that resemble Parkinson's syndrome. Now, this calcification in the brain, you can see all of this white material, which shouldn't be here, and the cataracts are the result of an elevation in something we call the calcium phosphate product. What's the calcium phosphate product? You take your serum calcium level number, you take your serum phosphate level number, you multiply them together, and that product is the calcium phosphate product. It should always be less than 55. And we'll talk more about that in a moment. Let's turn now to what your treatment options are, because this really is extremely important, and I'm pleased to say, an area of intense investigation that is yielding new hope for patients with hypoparathyroidism. So first, even before talking about your therapeutic options, let's address the therapeutic goals. What are we trying to achieve with treatment of hypoparathyroidism? Well, we like to achieve a serum calcium level of between 8 and 8.5, no lower than that. We may have to go a little higher in order to relieve symptoms in some patients, but for most patients with hypoparathyroidism, our treatment goal is a serum calcium level between 8 and 8.5. We're also trying to achieve a normal serum phosphate levels. And if I were with you in person today, I would ask you to raise your hands. How many of you have ever had your serum phosphate level measured? And it would not surprise me if no hands at all were raised. So every time you have your serum calcium level measured, you have to have your serum phosphate level measured. Both of these are important. You need to keep a serum calcium and phosphate product. Remember, that's just multiplying your serum calcium level number. Let's say that's 8 by your serum phosphate level. Let's say that's 8. 8 times 8 is 64. Not so good. Serum calcium of 8 with a phosphate level of 5, that's a product of 40. That's okay. So you should know your product. You need to have a urinary calcium level of less than 300 milligrams a day, or a goal we prefer to use because patients come in all different shapes and sizes, less than 4 milligrams per kilogram per day. Most of you may not know how much you weigh in kilograms. You just take your weight in pounds, multiply that by 2.2, and you get your weight in kilograms. So the average, years ago, the average, today it probably is no longer the average male weight was 70 kilograms. That's 154 pounds. I think I weighed that when I was 14. So you need to know what your weight is in kilograms. You need to keep your calcium level below 4 milligrams. So if you were a 70 milligram individual, You'd want your total to be less than 4 times 70. Your total in the urine should be less than 280. You also, for very obvious reasons, don't want to develop kidney stones. So that's important. And you want to have a relief of all the symptoms and enjoy a normal quality of life. So really, those are our therapeutic goals. And I'm sure that all of you would agree that these are very reasonable expectations for a patient. So conventional treatment, which I presume most of you are receiving, consists of oral calcium salts. Okay, here's something that perhaps some of you are unaware of. You need to take your calcium supplement with meals. That's because when you take the calcium with the meal, either right before or right after or during, when you take the calcium with meals, it prevents the phosphorus in your food from being absorbed. So in order to control blood calcium and blood phosphate, you need to take your calcium supplement with meals. And most patients will take about 500 to 1,000 milligrams of elemental calcium, and we'll talk more about that, 3 to 4 times a day. So it's got to be elemental calcium, not the calcium salt. 500 milligrams of calcium carbonate is only 200 milligrams of elemental calcium. So a standard Tums, which weighs 500 milligrams on the scale, and that's 500 milligrams of calcium carbonate, is only 200 milligrams of calcium. In addition to calcium, you'll need to take an activated form of vitamin D. Calcitriol is what most patients are taking. That's available in the US, but overseas, where calcitriol is not available, in Europe, for example, patients take a different form of activated vitamin D, something called 1-alpha. But you need to take one of these in order to replace the calcitriol that your body can no longer make. And many of you are also on a thiazide diuretic because you have an elevated urine calcium level. So this is conventional therapy: oral calcium salts, activated form of vitamin D, and a thiazide. Calcium should be given 3 or 4 times a day, not once a day. It should be given with meals. Calcitriol is a twice-a-day medication, not once a day. It's a twice-a-day medication. 1-alpha, the other form of activated vitamin D that is used in Europe, is once a day. But in the United States, if you're taking calcitriol, you probably should be taking it twice a day, not once a day. Okay. Now, getting more calcium. You can get it from your diet, but remember, most dairy food that contains a lot of calcium also contains a lot of phosphate, and we try to avoid phosphate. So most patients are going to get more calcium using calcium supplements. Calcium carbonate is 40% calcium. So a Tums that weighs 500 milligrams as calcium carbonate is only 200 milligrams of elemental calcium. Caltrate is also calcium carbonate. Citracal, which many of you are on, I'm sure, because Citracal is supposed to be kinder and more gentle to your intestine. Citracal has only 21% calcium, so the pills are larger and you often take more pills when you use calcium citrate compared to calcium carbonate. So calcium carbonate, more bang for the buck, and in fact, most forms of calcium carbonate are cheaper than calcium citrate. And most calcium carbonate is oyster shell. If you see bone calcium carbonate, avoid it, because calcium carbonate that comes from bone may be contaminated with lead or mercury or other heavy metals. So the calcium carbonate that's recommended is all from oyster shell. You can take an extra calcium tablet when you think you're low, when you feel some symptoms. I recommend that patients try to pop an extra calcium right before an exercise session because exercise will very predictably drop the serum calcium level, and you'll feel washed out after 30 minutes on the treadmill or a bicycle or even walking briskly for 30 minutes. So take an extra calcium before that exercise session. And calcium acts very rapidly as long as you've been taking calcitriol. If you take extra calcitriol, it'll take 4 to 6 hours before you see a change in your calcium level. If you take an extra calcium tablet, we can see changes, improvements in the serum calcium level in about 15 to 20 minutes. So if you're feeling low, take an extra calcium. If you wind up in the hospital for whatever reason and they need to do a calcium infusion, tell your doctors that the infusion of calcium should be continuous, not bolus. Bolus means they give you a big burst of IV calcium and then they stop, and 6 hours later, they do it again. And what happens is your calcium level goes way up from that burst, and then it goes way down, and then you get another burst, you're up and down, up and down, up and down all day, and you feel terrible. So a continuous infusion means they hook the IV up, the bottle has got calcium in it, and they infuse it constantly during your hospitalization. So bolus, no, infusion, yes. But remember, don't overdo the calcium. All that extra calcium has to go somewhere. It's going to go in your arteries, it'll go in your kidneys, it'll even go in your brain and your eyes. So don't overdo the calcium. There's a cost to that. And you got to watch the urine calcium. So you need to have spot urines done or a 24-hour urine done on a regular basis. Now, why is this so important? Okay, so this shows the amount of calcium in a random spot urine. You may go to the doctor's office and they tell you go pee in this cup and bring it in, fine. That's random. If they give you these big jugs, then you're going home and going to collect all your urine for 24 hours. That's more accurate, but it's easier to do the spot urine. Here's serum calcium. So a level of 2 millimole per liter is 8. And it turns out that once your blood calcium level is higher than 8 in a patient with hypoparathyroidism, urine calcium levels begin to go up like a rocket ship. And we want to keep the calcium to creatinine ratio. So in a spot urine, you don't know what the calcium excretion has been for 24 hours. You only know in that little spot. What we do is we look at the ratio of calcium to creatinine. We want to keep that ratio below 0.25. Below 0.25. So as your blood calcium level goes up higher and higher and higher, that ratio will also go up, putting you at increased risk of developing kidney stones. Now, let's look at a report card. How well do physicians do in monitoring urinary calcium? This is a paper published a number of years ago, 10 years ago now. How time flies. And investigators at Massachusetts General Hospital and Brigham and Women's Hospitals in Boston, these are two superb hospitals, always in the top 2 or 3 on US News and World Report. These investigators looked at their database and they found 120 patients with hypoparathyroidism. Over 2/3 were surgical, similar to, I think, all of you. And they found that less than half of these patients had a 24-hour urine collection for calcium. Less than half at 2 of the best hospitals in the United States. And when they looked at these patients who did have a 24-hour urine calcium, a quarter of them had calcium levels that were greater than 300 milligrams. So they're way up here, much too high. And at least 38% had one or more urine calcium levels that were greater than 300 milligrams. So this is not a very good report card at all. And why does this matter? What do we care about? Because these patients were developing kidney stones. So only about half of these patients, of the 120 charts they went through, only about half of these patients ever had any imaging of their kidneys. So ultrasound, CT scans, or both. And they found that a third of those patients who did have imaging showed stones. So stones are very common. Calcification of the kidney is very common in patients with hypoparathyroidism. But if we don't look at 24-hour urine calcium, if we don't do renal ultrasound, we don't know what's happening in the kidney. And why should we care? This is why we should care. Because patients with hypoparathyroidism in these orange bars have much higher percentages of renal insufficiency than patients with normal parathyroid function in the yellow bars. And you can see here individuals in the age of 60 to 69, 70% had some reduction in renal function compared to only about 15% of the normal population. So this is a big problem. You will develop renal problems if you don't know and control urinary calcium, if you don't know if you're getting renal calcification. So keep the urinary calcium level below 4 milligrams per kilogram per day. Make sure your serum calcium level isn't too high. If it is high, talk to your physician about thiazide diuretics. There's a pill called Modiuretic, which I think is the perfect pill. It's a combination of hydrochlorothiazide and amiloride. And I think it's a wonderful medication, Modiuretic, to keep the urinary calcium level low. But all of these different pills can drop your serum potassium. So if you're on a thiazide diuretic, you need to have your serum potassium checked as well. So get your urine calcium measured at least once a year. At least once a year, a 24-hour urine. You could get spot urine calciums 2 or 3 times a year and get a renal ultrasound every year or 2. Okay, some other calcium facts. Salt increases urinary calcium. I have a number of patients with surgical hypoparathyroidism that like an occasional margarita. And boy, that is loaded with salt. And they know that after a margarita, they're not going to get their urine calcium checked because they know that all the salt in that margarita will drive the urinary calcium level up. So whenever I ask them to do a 24-hour urine for me, they make sure they haven't had any margaritas or potato chips in order to avoid an elevated urinary calcium. Some of you may be on Lasix, and you should know that Lasix also drives calcium right through the kidney. So we see a high urinary calcium level in patients taking Lasix. On the other hand, thiazides, as I've already mentioned, will reduce urinary calcium. Hypothyroidism. So if you're not adjusted properly for your thyroid medication, if you are hypothyroid, that can lower your serum calcium. And some of you may be taking VEGF receptor inhibitors, tyrosine kinase inhibitor drugs. These, as well as steroids like prednisone, can also cause or worsen hypocalcemia. So a few other little tips about calcium. Now, phosphorus. Speed limit is 55. We want the calcium phosphate product less than 55, which means we need to keep the serum phosphate level in the normal range. Remember, if your doctor is giving you a slip and says, we're going to check your serum calcium, look at that slip. If there isn't a serum phosphate ordered as well, gently remind your physician, gee whiz, Dr. Levine says, in order to know my calcium phosphate product, I need to know my serum calcium level and my serum phosphate level. So get them both checked. And remember, this high phosphate level not only causes these calcifications in the eye, in the brain, in the kidney, it can also lower the serum calcium level. And how do we know that? We know that from reading Batman comics. Here we see an ancient Batman comic, and here Gotham City is to blame for turning me into living phosphorus. And what does that mean? So I will lower your serum calcium level. And I didn't modify these captions. These are real captions from this old Batman detective comic book. So what foods have a lot of phosphate and foods you should avoid or take in moderation? All dairy products. All dairy products are loaded with phosphate. Cola drinks, and even our friend Dr. Pepper. Dr. Pepper shouldn't be your doctor. Too much phosphate. Chocolate, nuts and butter, pancakes, my traditional Sunday morning breakfast, dried beans, processed meats, whole grains. You need to be aware these are very high phosphate foods. Now, if your serum phosphate levels are always running perfectly, then this isn't really very important for you to follow. But if your serum phosphate levels are too high, make sure you're taking your calcium supplements with meals and look at your food intake schedule to make sure you're not overdoing these high phosphate foods. We've talked about conventional therapy. What about newer forms of therapy for hypopara? What about PTH therapy? Well, this is really new. This is really new. If you call 1925 new, in 1925, J.B. Collop, who first purified for Lilly insulin, purified parathyroid extract for Lilly, and took this parathyroid extract and showed that if he took dogs that had their parathyroid glands removed surgically, and he gave these dogs parathyroid extract, he could restore their serum calcium levels to normal. And this was really quite remarkable because it showed that we could isolate parathyroid hormone from bovine parathyroid glands, and we could use this as a drug in dogs. Well, it didn't take but 4 years later for Fuller Albright, working at Massachusetts General Hospital in Boston, to get the idea if PTH worked for dogs with hypoparathyroidism, it would probably work for patients with hypoparathyroidism. So he went to the Lilly company that had been working with Dr. Collop, and he received some purified parathyroid extract, and he used this to treat a single patient who didn't have surgical hypopara. They didn't really know why the patient had hypopara, could have been autoimmune, but he gave the purified parathyroid extract to this patient, and the serum levels of calcium and phosphate both normalized. So if we think PTH therapy is new, we have to think that 1929 was also new. So the question is, do hypoparathyroidism patients need PTH therapy? Is conventional therapy not enough for them? Well, we know that not all patients are well controlled on conventional therapy. And I have, over the years, had many patients with surgical hypopara who just were extremely difficult to control. Some of them couldn't absorb the calcitriol reliably. Some had erratic swings, highs and lows, despite behaving perfectly, taking their medications, watching their diet. Their calcium levels would still swing. Some would have extremely high urinary calcium levels. So obviously, these patients were not responding well to conventional therapy. Other patients had normal levels of calcium and phosphate, but they just didn't feel well. Their quality of life was still in the dumps. And so about 25% of patients with hypoparathyroidism will not respond appropriately as well as we'd like to conventional therapy. And maybe these patients are the ones that would do best with parathyroid hormone replacement therapy. So in the modern era of the 21st century, we have PTH therapy as an emerging treatment. And I would add that parathyroid hormone replacement therapy is the last endocrine replacement therapy to have been developed. Just as the parathyroid glands were the last endocrine organs to be discovered, PTH therapy is the last hormonal replacement therapy in the endocrine system. Thyroid hormone replacement has been going on for 100 years. So PTH therapy is a lot more challenging. This is PTH. It has 84 amino acids. So the whole molecule is called 1-84. All of the working part of the molecule is in the first 34 amino acids. It's easier to make something that's 34 amino acids long than it is to make 84 amino acids. This makes sense. It's shorter. And 1-34 does all the heavy lifting for 1-84. So most people have used 1-34 in studies, and in work at the NIH and elsewhere, PTH 1-34 has been shown to be very effective in children and adults with hypoparathyroidism, but it had to be given 2 to 3 times a day or using an insulin pump for continuous infusion. It's not a one and done each day shot. Forteo is a form of 1-34 that is available to treat patients with osteoporosis. And it can be used for hypoparathyroidism, but again, it's 2 to 3 injections a day. I have some patients on pumps that deliver this continuously, and they do very well with continuous infusion using the pumps. Natpara is the 1-84 form, and it was a once-a-day injection that was effective as a once-a-day injection for most patients, but some people needed 2 injections a day. Unfortunately, several years ago, the FDA removed it from the market in the United States, still available in Europe, and it was removed by the FDA in the United States because the FDA had detected that some patients had vials where the seal had been broken and there were small rubber fragments in the vial. This never caused a problem that we're aware of in any of our patients, but was enough to cause the FDA to pull it. In development now, very exciting work with TransCon PTH. TransCon PTH is a once-a-day injection that is able to maintain levels of PTH throughout the day. Why is this important? If we look at levels of PTH throughout the day in patients who have normal parathyroid glands, we can see that levels of PTH are lowest right after breakfast. They're highest after midnight. And if we look at urine calcium, we see the reverse. When PTH levels go down, urine calcium levels go up. And when PTH levels go up, urine calcium levels go down. So the amount of calcium in the urine is controlled by the amount of PTH in the blood. So you'd like to have PTH present all 24 hours a day after one injection. And the TransCon PTH can do that. So TransCon PTH consists of the working portion of PTH, 1-34. It's hooked on through a linker to a molecule called polyethylene glycol. It's totally inert. This is injected over time. The linker breaks down, releasing PTH slowly over 24 hours. This maintains measurable levels of PTH 1-34 over the entire 24 hours after an injection. What does that mean? Well, here's a phase 2 trial result published earlier this year in the Journal of Clinical Endocrinology and Metabolism. It showed that 91% of patients were able to stop their calcitriol and reduce their calcium supplements to 500 milligrams a day or less. And 76% of patients eliminated calcitriol and calcium completely. One injection a day, nothing else. And what I think is really most important, there was a big decrease in the average urinary calcium excretion from 415 milligrams a day to 178. So normalization of urinary calcium levels. This drug is still under development. We don't have it yet. It's generally well tolerated. Some patients got a little dizzy, some had headaches, and it also importantly improved several indices related to quality of life. So I think, stay tuned for TransCon PTH 1 to 34. All the data so far show that it will be an effective once-a-day injection that will control serum calcium and phosphate, urine calcium, and improve quality of life. So last, how to monitor treatment. We need to monitor serum calcium and albumin, and I'll tell you why in a moment. We need to monitor the phosphorus. We need to look at serum creatinine to look at renal function. And in some patients, particularly on diuretics, we need to look at magnesium. We need once a year to make sure that your vitamin D status is normal by checking a 25-hydroxyvitamin D. And once a year, at least a 24-hour urine for calcium, creatinine, and sodium, because sodium intake, your salt intake, will influence your urinary calcium excretion. And then once every year or every couple of years, a renal ultrasound. There's no radiation, and it's the best way to look for renal calcifications. Now, why measure albumin, which is a protein in the blood, when you measure calcium? And the reason is simple. About half of calcium, shown in red here, is circulating bound to albumin. If your albumin level is low, then the total calcium will be low. Even though the ionized calcium, shown here in light green, maybe that's mint, is normal. So ionized calcium is always going to be the best test to look at your calcium level, the ionized calcium. But that's sometimes difficult to get. So if your doctor orders a total calcium, make sure they check the albumin, because if the blood albumin level is low, the total calcium can be falsely low. And if the tourniquet remains on your arm too long, because there's a difficulty in getting the blood sample, that can cause the blood albumin level to become more concentrated, which can raise the total calcium and make it appear that your serum calcium level is normal or elevated, even though you're feeling low. So you always want to get that albumin level as well when you get your serum calcium level. So total serum calcium with albumin, you want to keep that 8 to 8.5, the lower end of the reference range, as long as that relieves your symptoms. You want to avoid higher calcium levels than you need to relieve your symptoms, because all that extra calcium goes into the urine. Now, what about bone density? Is a question I'm asked all the time, because most patients with surgical hypoparathyroidism are women age 50 and older. And we know that in patients who've had hypopara for a long time, bone density actually is higher than normal. We don't understand what the clinical significance of this is. There doesn't appear to be any evidence that this higher bone density is good, bad, or otherwise important. So a baseline DEXA is reasonable in all patients with hypopara, and then follow up as appropriate. but you don't need annual DEXA just because you have hypopara. So here's my summary. Hypocalcemia is the principal manifestation of hypopara, but remember, phosphate is important. Measure that phosphate, and urine calcium is important. So with treatment, this has got to be monitored closely. Renal ultrasound, 24-hour urine calcium, blood calcium, and blood phosphate. An optimal response requires a close partnership between the patient and the physician. So let me end at this point, and perhaps there are some questions in the Q&A. It looks like there might be 10, and Deb will ask me these questions, and I will speak very quickly to get through them. Thank you for your attention. Deb, I think you're muted.
I'm unmuted now.
Okay, excellent.
Thank you so much for that presentation. Yes, we do have questions. Lindsay asks, despite maintaining stable calcium levels with calcitrol and calcium supplements, I get foot and hamstring cramps quite often. Is this common?
Well, it is common, and it could be the result of measuring your calcium levels at times when you're not symptomatic. It's always best to measure your calcium level when you're feeling symptomatic. So one possibility is that your symptoms and your lab visits are not in alignment. Another possibility is that your potassium or magnesium are low, and they can also cause cramps. So next time you get a blood test, check the magnesium and potassium along with calcium and your phosphate.
Okay, thank you. I have a permanent hypoparathyroidism since thyroid surgery in 2012. Post-pregnancy, my calcium levels normalized and I did not need supplements. However, as soon as I stopped breastfeeding, my calcium levels dropped and I needed to go back on calcium. Have you ever heard of this or aware of a correlation?
It's very common. During pregnancy, in the latter part of pregnancy, the placenta begins to make 125. And so we see decreasing requirements for calcitriol or calcium in the last trimester. And if women do breastfeed, the prolactin that they're producing that is used to support milk supply can also help produce calcitriol within the body. So this is a fantastic description of a well-known phenomenon.
Sierra writes, I had a total thyroidectomy. How do I know if I still have my parathyroid glands?
So the easiest way to know this is to check your calcium and phosphate. I wouldn't check PTH first. If your calcium and phosphate are normal, then you have some parathyroid tissue left that's producing parathyroid hormone. Let me add this caveat. Some patients will have a condition that we call parathyroid insufficiency. And by that, I mean during everyday life, they're able to make enough PTH to keep their calcium and phosphate levels normal. But if they get a bad fever, if they get a cold, if they go to the hospital for an operation and their body is under stress, they may not have enough parathyroid reserve to control their calcium and phosphate. So these are patients that every day walking around, calcium and phosphate are normal, but under severe medical stress, their calcium levels will plummet. PTH levels really won't help you. Looking at your calcium and phosphate level is the key.
Okay, Jessica says, I have been on calcitrol and oyster calcium for 2 years. The surgeons are still monitoring this. Recently, she asked the endocrine to work to monitor, and they did not have a urine. They just measure my calcium. Who do I work with to get these tests?
So you should work with an endocrinologist who understands hypoparathyroidism. Not every endocrinologist treats hypoparathyroidism or has many patients with hypoparathyroidism. For example, I don't treat diabetes. There's no way that I can be as good managing a patient with diabetes as one of my colleagues who does diabetes day in, day out. So you need to find an endocrinologist who's excellent in hypopara. If there isn't one in your area, then maybe you need to go somewhere else once a year to establish a relationship with a hypoparathyroidism expert. Our Hypoparathyroidism Association has a long list of these experts. And if you see that expert once, you'll get a recommendation that you bring back to your local endocrinologist, who then can follow that plan.
Perfect. And we're out of time. So if we didn't answer your question, please send your questions back to ThyCa, and we will get them answered as quickly as possible.
Or you can send questions to me directly at my email box. I've given you my email address, and I'll do my best to respond to questions that are sent to me by email.
Thank you so much, Dr. Levine. We have really enjoyed this.
All right. Thank you, everybody, for your attention. Have a great rest of your day.
Bye-bye.